Hey, Chantel. Oh, session's being recorded. I see. That's good.
Hi, Leah.
Hi, is that
Hi,
Chantel?
Lori. Hi. Okay, I'm under control here now. I was just trying to figure out how to do that. So yeah, we are in recording. Okay.
Fantastic. Thanks, Chantel. We only have only Barry's joined us thus far. We still have people
Okay, great.
to
Not a problem.
join. So
Not a
yeah,
problem.
that's great. Thanks,
Okay.
Chantel.
Bye.
Bye. Ah, yay, tech problem solved. So how's life in your neck of the woods, Barry?
Um, well, you've been watching the news, need I
I
say?
know oh yeah, it feels like it's all very surreal and yet it's real. So yeah,
Yeah,
it's like we're
something.
living in dystopian realities. Well, we just elected a not genius premier in our province too. So populism is taking
At least
over.
Russia didn't elect him for you.
Though it does look like he may have cheated to even become a candidate, but yeah, I feel you. I feel you. Oh my
Oh,
goodness.
your guy?
What's that? Yeah, our guy. It's yeah,
Mm.
it's all a bit smelly. Hi, Carol. I think you're on mute. Welcome.
This is Mark Lawrence.
Oh, hi, Mark. Welcome.
Thank you. How are you?
Very well. How are you doing?
I'm good, thanks.
Good.
Can you hear me now?
Perfectly.
Okay.
Hi, Carol.
Thank you. Hi.
I think there's three of us on the line, plus our amazing assistant Chantel, who's in the background recording us. We're expecting more, so we'll just give it a bit. Hopefully people aren't too late. I think I see Gilbert coming online. Hi, Gilbert. How are you doing, Gilbert?
I'm okay, Leah. How are you?
Very well, thanks. Welcome to the call.
Thank you.
Hello.
Hi, Louise.
Hi.
How are you today?
I'm okay. I'm not in a very conducive place for this call, unfortunately. I had a meeting downtown and I didn't get home from it. It's kind of noisy where I am. So anyways, it is what it is, right?
It is what it is, but actually it sounds pretty good. We don't hear any background noise at this point. At least I don't.
So. Oh, that's good.
Yay.
Yeah.
So far we have Barry, Carol Reese, Mark Lawrence, Gilbert, Mwabaze, and yourself on the call. And
Antonella.
Hey.
Antonella.
Hi, Antonella.
Hello. Hi, guys. My partner in crime here.
Exactly. And Carol paired up with me to be my partner in crime for Chapter 2, so we're good.
Excellent.
Yay. Do I see Elizabeth Lai on the line? I think you might be muted, Elizabeth, but welcome.
Yeah, I'm here. Thanks. Sorry I'm late.
No, that's okay. People are still joining. So we'll give it another couple of minutes, maybe no later than 12:05, and then get going. And in our agenda today, we're jumping into the meat of the book. The Louise and Antonella will get us started with Chapter 1, and then Carol Reese and myself worked on Chapter 2, and we'll have lots of discussion about these meaty chapters. And then to finish up, if we have just a little bit of time at the end, we'll just encourage some signing up for those who haven't had a chance to sign up yet, and just remind ourselves of our next meeting date and time. Sound like a good agenda to everyone?
Yep, that's fine.
Thank you.
Yeah. Great. I welcome Martina. I see you joining. I think that's Martina Wood, most likely.
Hi, Martina.
I think she's just coming online still. Looks like. She's still a gray phone symbol rather than a green one. So just checking in, do we have others on the line outside of Barry, Carol, Mark, Gilbert, Louise, Antonella, Elizabeth, and Martina? Did I miss anybody?
Yeah, Martina.
Hi.
Hi.
Well, great to hear your voice. How are you?
I'm fine. How are you?
Very well, thanks.
Good.
Hope you're enjoying the summer.
Yeah. Oh, yeah, I am. Yeah.
Great.
And I haven't got the book yet, so.
Oh, no, hasn't arrived yet?
No, but I've looked at your notes, so interesting.
Good stuff. Great. It's well, I don't know. For some of us, it's a pretty intense read. It's dense ideas.
Yeah.
That's my impression, anyways. I don't know about others. I think Carol shared my feeling, at least about our chapter. Okay, it's 12:04, so let's get started with who we have online, and then we can catch people up if needed. So just double checking that I haven't missed anybody. Barry, Carol, Mark, Gilbert, Louise, Antonella, Elizabeth, and Martina. Welcome. This is Leah speaking. Is there anyone else on the line that I missed? Okie dokie. I know we got regrets from a few people. Fabiana, Cherlane, Leah, Stephanie, and Kathy. Oh, Kathy Kovacs-Burns and Rose. And they all plan on listening in to the recording. Thanks to Chantel Burrows for recording this for us. And she'll put it up on YouTube like last time. And so we can go back and remind ourselves of the conversation, which I thought audio would be better than notes, since, you know, it's conversation gets pretty dense. And notes would definitely synthesize any conversation. So hi, John. I see you joining as well. Welcome. Okay, so let's jump in. Chapter 1 of Redefining Healthcare, and I believe it's called Scoping the Problem.
Scoping the Problem, yeah.
So over to Louise and Antonella, who kindly agreed to facilitate this chapter.
Louise, do you want me to introduce it, and then
Sure.
Okay. So, so scoping the problem, it is a big problem, but a short chapter. So they pack in a lot of data that is, it's very American-centric, of course, but they do provide some data that looks at comparisons across countries from early 2000s, so I think 2004. But overall, I'll give an overall idea of what the chapter talks about, and Louise, you can jump in, and then we'll talk a little bit about what we did to look at some current Canadian data. But overall, the chapter really talks about the under-provision of care. And this is roughly equal across broad types of treatment, so preventative care, acute care, and chronic care. And it really highlights indicators that show that there are several problems affecting the system. And that not only is the system not meeting the needs of people, but that Americans believe that they're getting their money's worth. So they are, they're dissatisfied with the system, but they're also not fully comprehending the extent of the issues. So we looked at, so the chapter looks at a few, the indicators that it looks at include things like medical errors, administrative costs, the gap between the quality of care that people should receive and what they are actually receiving. And it also looks at the cost and how there's, you know, growth in insurance premiums have outpaced wage growth by a factor of 4 and inflation by a factor of 6. So not only are we not, is the, you know, the populace not getting the treatment and supports it needs through the healthcare system, but they're also paying more for it. So that's the gist of the chapter. Louise, do you want to add anything?
Yeah, I'll just add a couple of things. Although this is, although much of the data here are American, the problem is clearly international. So, I mean, basically what, as Antonella says, the two of the main themes are that they're paying a lot and not getting the quality they should. So cost and expense doesn't necessarily equal quality. And that, I think we would say the same in Canada. I don't think there's any doubt that we're paying a lot, either through taxes or through co-pays and deductibles, but we're not really seeing the outcomes that we'd like. Now, one of the things I think that's important to keep in mind in Canada is that we don't actually know the extent of the waste and inefficiencies in our system, because we don't have good data analysis of the parts of the different parts of the healthcare budget. And I think that's a point that we should kind of keep in mind as we go through this book, because it is a key point. I mean, how do you know where your problems are or where your inefficiencies are if you're not really measuring them? And I think that's it probably isn't a discreetly Canadian problem, but it's definitely a Canadian problem. And the other point that Antonella made that I think is equally true for Canada as it is for the United States and probably many other countries is that we really don't understand the extent to which there is a misalignment between what we think we're getting for the money we're spending and what we actually are getting. And I would say also that in Canada, not only we don't understand it, but we don't understand why. Even when we have a sense that we're not getting what we should, we don't really understand our systems well enough to understand why we're not getting it. Yeah, I just thought I'd, sort of help contextualize that a bit to Canada.
Exactly. So, Louise, do you want to talk a little bit about some of the information that we tried to get?
Well, my problem is that I'm not at home, so I'm not in front of my computer, so I don't have those data in front of me. So I'm probably going to have to rely on you for some of the numbers. But just to say that one of the things I liked about this chapter, as Antonella said, it's short, but it uses a lot of data in other than words, it uses it in charts, and I personally really like that way of seeing things. I guess everybody likes different ways of seeing things, but to me these charts are really useful, and kind of a picture being worth 1,000 words, I think. So so I thought that was really good, but as she said, we didn't, some of them include comparative data, country to country, and Canada, where it does, Canada's included, but a lot of it is U.S. data. So we asked our colleague Rose Tong, who's been working on doing some environmental scanning in Canada about waste and inefficiencies, if she might have something comparable that we might be able to share from a Canadian perspective. So, and she did provide us with some things. So maybe, Antonella, do you want to talk a bit about what we learned?
Yeah. So this is, I'll give you some highlights around some of the inefficiencies that Rose and her colleagues captured in looking at a kind of nationwide analysis of healthcare, and really more of a kind of overall review versus metrics, that the way that they are laid out in this chapter. So I'll give you some highlights, and as we said, the data may not be captured effectively across the healthcare system to actually know what our gaps are and what benchmarks are for certain things. However, literature and what does exist does show that these inefficiencies are clear across the board, and there's work to be done here. So I'll highlight a little bit of what Rose did send us. Things like in terms of prevention and population health, which is one of the areas that they touch on in this chapter, things that are very much missing from our current system in Canada is not enough focus on determinants of health. So, what we are measuring doesn't necessarily take into account how these how social determinants of health impact health outcomes, and there's gaps in measuring how those social determinants affect people differently across specifically healthcare prevention. And so the idea that was put forth in looking at the literature around this was that there's need to focus on sound primary care practices and population health approaches, particularly preventing and managing chronic diseases. So that's a big gap that was pointed out in the data that Rose is looking at and her group is looking at. And then the fact that, the responsibility for healthcare delivery and administration is highly decentralized in Canada, and that speaks to that problem as well in terms of, where we find this data and information to be able to actually measure outcomes. And then there's, again, a continued need to focus greater attention on disease prevention and equitable access to care that we don't know as well as we'd like to. In terms of human resources, the data that they found points to Canada having significantly fewer physicians than OECD averages. There are fewer acute care beds than OECD average, half the number, and fewer psychiatric beds per capita compared to the average of OECD country. So metrics that we do have show that there are gaps in human resources and resources within the hospital system. And then things like technology and equipment, how we compare in terms of technology and diagnostic imaging resources. What they found is that Canada ranks 19th out of 26 for MRI units, 19th out of 26 for CT scanners, and 15th out of 24 for PET scanners, which, again, these are indicators as to how we're doing on a global scale that we can build on and look at if we need to in our work in this area. And similarly, I'm not going to go through all these because there's so many, but I'm going to highlight a couple more. In terms of hospitals and acute care, there are, again, what the analysis found was that there are low hospital discharge rates, overuse of emergency departments, and high readmission rates after discharge from hospital. I think this is across health issues. Wait times in emergency rooms are high, and wait times for surgery are high. So again, we could dig deeper into any of these metrics if we needed to, because of information that they found. And then I'll just highlight the family doctors that they found in their analysis. The current fee-for-service payment models incentivize short and frequent visits, which can be particularly challenging for those with chronic diseases. And again, the current fee-for-service model fosters a provider-centered rather than a patient-centered approach to service delivery, reinforcing the perception of those traditionally autonomous physicians. And so that speaks to a little bit about how the chapter ends off and what this whole book is about in terms of competition not being a part of our current system and it necessary for driving success. And then, yeah, so other indicators that they, or analysis that they did just found that some inefficiencies have to do with the lack of integration between acute and community care, as we all know, and the need to prioritize cross-sectoral planning and break down the silos along the continuum of care. And then aligned with that, not enough post-acute care settings to provide rehab and long-term care services, lack of electronic records. So I could go on and on, which I won't, but I'm just highlighting some of the data that we do have a little bit of analysis on. In addition to the areas I mentioned, there's also things around or analysis around inefficiencies in access, cost, performance monitoring, and private insurance. And I don't know how we're going to go forward with this, but it could be, we could share this information with the group as long as we get permission from the work that Rose is doing. But all to say that the information we do have readily available does show a lot of corresponding challenges and inefficiencies with the American data, or the challenges that are highlighted in the chapter for the US, and can help us build a case for the similar challenges in Canada I hope that wasn't too much, but that's the gist of it. Do you want to add anything, Louise, or comment on any of that?
No, I think I think that's great. I don't know if there are any other metrics that they did not analyze in this that you think that anybody on the call thinks might be relevant for the Canadian context. We've got healthcare expenditures and life expectancy. We've got gaps between, they call it what is known to work and delivered care. So what is known to work, in other words, sort of best practice, our clinical guidelines, appropriate care and delivered care, recommend that guidelines as well. And then they get more granular about that in describing different disease groups rather than rolling them up. Health in hospital deaths due to medical error, and in hospital deaths due to they've got a couple of those different ways of looking at those. And adverse events, which I think is always an important one, where you can measure them, and expenses per patient day, average costs for Medicare, their Medicare system. So I think they cover a number of the indicators that are relevant. I'm not sure if anybody has any others that they think would be useful for us to be capturing at this stage. Does anybody think of anything that they see missing there that they'd really like to know in terms of what's going on in our system right now?
Yeah, it's Barry. Hi. I mean, the big thing that jumped out to me is that what they're looking at to just figure out what's not working is more around cost cutting, measures versus health outcomes. It's like health outcomes is like really not being captured at all, and certainly not, in a integrated, useful across the board form. And the other problem is overcare. And I can use my own situation as an example. I have a fee-for-service plan, and I'm constantly got providers trying to give me unnecessary stuff so they can rack up, dollars. So it's not just people not getting enough care, but some people are getting care that they don't need and too much of it.
Yeah, that's a very good point. One of the programs that I think has attempted to start to deal with that a little bit is the Canadian Medical Association's Choosing Wisely campaign. I'm not sure if we can get any data about how well that program has. I wonder if there's any data about whether it's achieved any goals that it's set in terms of overcare.
I think there have been some publications on it. From what I can see in LinkedIn, I've seen some folks posting about Choose Wisely publications. So I think if Rose were to Google that or to search some databases, she'd probably find something.
Yeah, that might be interesting. I would mention that I think that's worth mentioning to Rose too, in terms of the sort of inefficiencies and waste that they're looking at.
It looks like on their website they've got a pretty robust selection of recommendations and resources across different illness areas. So it definitely looks like there's a lot of data here or information.
If it's possible,
the question is it achieving anything?
Well, that's to Barry's bigger point. Just clearly there is a systems absence on measuring outcomes, right? Because what we're getting are a lot of different sort of indicators, but obviously that data isn't there, and that's certainly reiterated over and over again in all the chapters. But Is it possible, if it's possible, to share this data with, I don't know about others in the group, but I think it'd be really interesting to take a look at it and to mull on that question of is there anything else in the Canadian context that we think could be helpful to understand in terms of scoping the problem or the current state. But yeah, this is amazing. May I ask what context she's doing this homework this homework in, or is it too early to share?
It's for the All-Can Canada.
Okay.
Sorry, I'm sneezing with my allergies. All-Can Canada program that she's working on.
Oh, fantastic. This is very helpful.
Louise, can I, should I ask Rose if we can share the documents at this stage?
Well, I think the first, well.
Too early?
Yeah, I'm not sure they're in. I think it's a bit early. I don't think they've done an analysis of it themselves yet.
Okay.
Right.
Okay.
So it's kind of just raw. So I don't know that she'd feel comfortable to draw any conclusions from it, at least, you know, not attributable to her anyways.
Yeah. Maybe we can ask her if we can share just the categories that they're looking at.
Sure, that would be good. And I do think that I would identify for her this the potential to take a closer look at over prescribing and over caring, too much care.
Yeah, too many diagnoses and too many tests.
Okay, I'll ask her after we're done with this call, just in case there's anything else we have to ask or suggest. So great.
Okay, yeah, sure. So I think, you know, I mean, certainly the data that are there make the case from my perspective, you know, convince me that we need to do something better, that we're not getting good value for money, that we're not measuring what value we are getting. And as Barry says, we're not certainly not measuring it against patient-reported outcome measures. So maybe the system feels like we're achieving something, but do the patients feel that we're achieving something? That's a completely different lens. I mean, things can be working very well and be very efficient, but not necessarily achieving what they ought to be achieving. That's a completely different sort of set of measures, right?
Yeah. Louise, it's Antonella, just to add to that point and to the last comment about actual health outcomes, it's that quality of life outcome measurement as well, because that's also like the person's experience through the system. And like you said, like even if you're receiving the best care according to the system, how was that person's experience through it? And did it actually not just meet their health needs, but their quality of life needs and their experience? So I don't know if that's, I don't know if those are like objective measures or quality of life measures, but those are often missing even when we talk about health outcomes according to the person.
Yeah. Can I say something?
Please jump in.
May I? Okay. It's Martina, and I understand where everyone's coming from in terms of saying that the care or the outcomes are suboptimal. I've had some experiences with my mother recently. A couple of months ago, she she was hospitalized because she had a ruptured appendix, and due to a bunch of health issues, she almost died in the hospital while waiting. She had a room. She had to wait 3 days because she was on blood thinners. Then they did the surgery, even though it was touch and go. They said every day that they wait, it's harder on her heart. And but anyways, the outcome was that they made sure that she survived the operation, and then she survived and came out of the hospital. And a month later, she got a pacemaker, and she's doing very well. And the care she got was really, really good. She's been in the hospital a few times, because she's, 80 something, and she's got some issues. And the only time that we've had a problem was when she fell and broke her hip bone or something a few years ago, and they had her in emergency in the hallway for like 24, more than a day, while they waited to have her get surgery. And that was not a good situation, but every other situation has been really, really good. And and also my own experiences with the healthcare system have been good. My only comment is that when dealing with oncologists is that sometimes they think that they are God and you are nothing, and that's a personality issue. That's a training. The doctor is kind of educating them in terms of bedside manner stuff, but in terms of quality of care and outcomes, so far so good. So does everybody have a really big beef about outcomes, or are we taking that position from a theoretical standpoint to push the envelope and make things better?
I'm personally not taking that as I'm not taking it theoretically, and that's why these data are the measures. Like, I mean, I've had good and bad experiences, like you. I've had some really great experiences that I would personally put down to the people who were treating me, not to the system, but to some amazing people who treated me really well, right? And I've had some really terrible experiences, often also related to people who I thought were not doing their job very well. So, and some of that may be the system too. Maybe the reason they weren't doing their job very well, sort of not known to me, is because the system didn't give them a chance to. I don't know. I just know what I experienced, right? Which was the person in front of me either doing a really good job or doing a really bad job. But I I personally don't want to do anything just out of theory. I mean, the point here is if it will improve our system and improve the care and the outcomes that people get, then let's do it. If everything is fine or fine enough, then not. How do we figure out if it's fine enough? I think what they attempted to do in this, in this chapter was to give us some data that might suggest why systemically, not necessarily individually, but systemically, we're not doing as well as we could. And I guess that was the question that Antonella and I was asking about, are there other things you think we should be measuring that will give us even a better idea of whether the system is doing well or not? Mm-hmm. So, yeah.
And I think just from some of the system level data that was being shared, there are signs of problems. So when hospitals in acute care have high admission rates to the emergency department, when there's long wait times in the emergency room, that's a symptom. And the other comments about investments in community care. These data start to tell a picture, right? So why are you having the backup in the hospital system? And there's similar measurements around ALC beds, or so that alternative use of, like, when beds aren't being used for hospitals, but they're being used for other purposes that they ought not be. So those beds aren't available. It's showing the capacity issues on the community side, and that inability to move people. Either because it doesn't exist or because there isn't active linkages to the needed supports in other settings, right? So even within this data, it's showing us where those the bump and grind is, and I think it's important to look at it at the sort of aggregate data level and at the systems level, because yes, we've all had positive and negative experiences of care. So the lack of diagnostic equipment that was being mentioned, for example. I certainly came up against that as a caregiver with my mom dealing with cancer. Couldn't get certain types of diagnostics in Ontario at all, PET-CT specifically. But that kind of stuff, is very variable from person to person, from jurisdiction to jurisdiction. So doing our best to actually see what are those indicators, since we don't generally have larger outcome measures currently, but what other types of indicators do we have that give us a sense of what is happening inside of the system? I don't know if they're looking at things like expenditures and sort of allocations across different parts of the system. That would also be interesting, I think, for Rose's work, if they're actually looking at, sort of just the larger trends in terms of health budget allocations, how much is going towards acute or to medical physicians, to specialists, to long-term care, to mental, to other types of settings. And I think that could be helpful information too.
For sure, and certainly I'm fully on board with, having the eye specialists, the eye surgeons, giving up some of their marvelous income due to the technologies that have changed and made it so much easier and faster to do procedures. Just a question, two questions, but one of them is the statistics that are mentioned, are they taken from the book?
Yes.
Yeah, and so the book is published like 13 years ago, right? Is that right? Or is there a more recent one?
Yeah, so the data that's captured in the book is from 2004, a lot of a lot of the tables.
So we should keep that in mind, that the data is dated. Okay, and one could assume that things have worsened over time, or we could assume that things have gotten better, or we can check that. I think that using those pieces of information may not be the best foundation, okay, because we don't know for sure how things have changed.
And just to clarify, Martina, that's the U.S. data in the book. So the Canadian data that they were chatting about, that Rose has been researching, that'll be whatever's more current, up to date. That'll be
exactly. The Canadian stuff's current.
Now, do you has anybody looked on the OHA website? There's something called Redefining Healthcare that they've got some kind of publications. I haven't actually read any of it, but has anybody explored that?
No,
not the OHA. No.
Okay, it's on the Ontario Hospital Association website, and it's called Redefining Healthcare, and they've got 3 different things here, which we can sign up for to read, etc. The other thing is, in terms of long-term care, did anybody see the series of articles in the Toronto Star about an experimental way of dealing with residents in long-term care homes that was in the Toronto Star last week?
I did. It was really interesting.
It was, wasn't it? Yeah.
Yes.
And it's a great way to move forward with long-term care. And since, everybody's getting older, I mean, we all want to have love and care and happiness and memories, and so and apparently it costs a little bit more because they have to add more workers. They have to add 5 more workers, so they need a budget for that. But that's kind of where I would say, okay, yes, definitely we have a shortfall in terms of quality of life in those organizations, in those residences. So that's my piece.
Definitely. Yeah, I mean, that's actually an excellent example of patient-reported outcome measures that could, obviously there was a dissatisfaction with the outcomes that they were getting, or at least they weren't very happy, and they brought in, as I read the articles, they brought in a group that actually did measure how they were doing based on quality of life measures and other patient-reported outcomes. And this nursing home group actually, I think, scored the worst of all the 5 countries and all the organizations in it that they measured, which of course was very disturbing to them, but very courageous of them to still, bring those people in and learn that about themselves. And so it's an interesting story of kind of what are you measuring, you know? And the minute they decide, they thought they were doing pretty well. They had really received pretty good marks based on getting people fed and clothed and getting them their medications on time and that sort of thing. But all the things that actually mattered to the patients, they weren't doing at all. And so that's a great example of, you know, depends on what you're measuring.
Yeah,
That's
right.
And having not read the story, did they then make improvements basically based on what they learned?
Oh, they completely revised this group that did the analysis for them had a completely different system in terms of looking after people with dementia and Alzheimer's and other memory related issues. And they completely changed the way they were doing business.
Fabulous.
And it's just, it was really it's a great example of what can happen if people want it to.
And when you say that they completely revamped it, you know, the description really is that the workers started to wear street clothes. The workers started to touch the even like hug the residents. They talked to them. They didn't spend oodles of time once an hour trying to complete forms. Because what happens in those places is they have time limits to get everybody dressed and ready, for instance. And so they have to slap everyone together and when you're older, you need time to adjust to the fact, okay, it's morning, okay, I need to get dressed. And so they were starting to take time and treat everybody as an individual instead of as a widget on an assembly line.
Very interesting.
And it was very interesting. And they also took into account the fact that these folks, you know, maybe didn't really remember what was going on with them today. And if they really thought, as they say in the article, you know, if the person really thought they were still 10 years old and at home waiting for their parents to come home, so you just went with that. You know, you didn't try to logic them into thinking something different than what they were thinking, because you can't anyway.
You're motivated from the place where they're at.
Yeah, exactly. You deal with where they're at.
And bring in music and memories, you know, so.
Whatever they needed.
I'm having two thoughts. Number one, Barry was sending a link, wondering if this was the story. Barry, it looks like that's an opinion letter or a letter that someone wrote about the story. Is it possible, either Louise or Martina, if you could share the link with the group? I think we'd love to take a read. And also, I'm just wondering, I'll bring it up on our steering committee call, but maybe this is for our panel of Canadian promising practices at the summit.
Absolutely. I think it's fascinating.
Yeah, I think that's a very interesting example of a group that basically, you know, started looking at some better outcome measures from the perspective of the users, of the clients, and did a meaningful job at you know, quality improvement, and presumably they'll continue to look at these measures and others of importance, and you know, looking more towards outcomes and outcomes of importance to the patients, and continue to try to improve and adapt. So yeah, that's exciting, and it sounds like a lot of
exciting
interventions. Well, no, it's an exciting example of sort of based healthcare, right? And again, look at a lot of the changes that they had to make are very low cost, right? What you wear, how you work with people. It's not. There's no big expense in any of this, right? And yet,
I think that Martina's right. The big expense is that it takes more time, and therefore they did need more resources. I think that was the biggest thing. Yeah.
Right. The people to do this well, and enough time to do it. Yeah. Excellent example. So just in the interest of time,
I don't have a link. I actually am one of the last people in the world who actually still gets a newspaper. So I actually had the article. I was actually reading them, but I mean, we could find it. Martina, did you read them online by any chance?
No, I read them in the paper, but I am.
So you're like me. Good.
Yeah. I like the newspaper. But I do. I have found them online, so I'll send them to Leah, and she can.
Oh, that's great. Thank you.
Okay.
Thanks so much.
Yeah, no problem.
So I think in about 2 minutes or so, we should move on to chapter 2. Did anyone else have anything else they wanted to add to the discussion about chapter 1, scoping the problem? Well, this has been really interesting, and it's fantastic that you were able to bring so much Canadian data forward. Really, really helpful, and an exciting example of of this long-term care home that has integrated proms into how they operate and are making pretty significant, it sounds like, improvements in certainly patient experience, and I wouldn't be surprised if over time, as they keep measuring, in health outcomes.
Oh, I'm sure.
So, yeah.
Yeah.
That's great. Any last comments before we jump into chapter 2? Okie dokie. So for chapter 2, I loved Antonella's summary that chapter 1 was, what'd you say? It was like short but dense or something along this line. So chapter 2 is long and dense.
We looked out and least. Oh yeah.
And just so Carol very kindly is going to take us through. We did pull together a few slides because there is a lot of content, and just so people who aren't on the call, if they couldn't listen to the audio and stuff, they'd have something to reference to. We just tried to kind of summarize the key messages, but also build in any Canadian examples that we were aware of, or Canadian dynamics that we were aware of. We built those in along as part of it. And so hopefully those of you who are on the call can see the slides. I just shared my screen. If any of you can't, let me know. If you're on the phone, obviously you can't see them, but we sent them in advance, so you can look at them if you want. And please feel free to just jump in at any point if you've had any thoughts or ideas about that part of the chapter that you want to share. Just jump right in. Don't be shy. But I'm going to hand it over to Carol, and I'll just move the slides along for you, Carol, and I'll jump in if there's anything that I want to add to.
Sure.
Thank you
All
so
right.
much.
Yeah, this is a big chapter. I volunteered before looking at it. Always a good thing. So identifying root causes. So I'll try to condense everything just for the sake of time, then we can discuss further and so forth. So zero-sum competition, one section. Basically, it aims to redivide the pie, which is basically what the US and the Canadian healthcare system is doing. And this leads to competition at all the wrong levels. So what it does is it creates competition to shift costs. It increases bargaining power. It increases competition to capture patients and also restrict their choices. Competition to reduce costs by restricting services. So basically, these are just dysfunctional types of competition, and it's not focused on delivering value at all.
Mm-hmm. And they contrast this to positive sum competition, which is really looking to expand the pie, and that ultimately is the goal of an approach like value-based healthcare, is to bring in healthy positive sum competition instead of this negative winners and losers zero-sum competition that's currently the dynamic, and where nobody wins basically, especially in including customers, patients, people, but nobody wins ultimately, really, in the way that it plays out in zero-sum competition.
And then slide 3, zero-sum competition to shift costs. So some examples from Canada. We have our public formularies that don't cover treatment, so shifting the cost to people for them to pay out of pocket. We have our private healthcare plans, which they will restrict coverage and require people to get what they need from the public plan, or they will have to pay out of pocket. So patients are required to pay increasing user fees and co-payments.
So these are just a few examples that we were brainstorming of some of the different cost shifting type of dynamics that play out in Canada, and I'm sure those of you on the line have lots of other examples, so feel free to just jump in with any that you want to flag. We just grabbed a couple here. Nope.
Any comments?
Okay. We'll keep going. All right.
Yeah. Okay. Zero-sum competition to increase bargaining power. Did you want to speak to this one, or do you want me to speak to this?
Sure, yeah, and I'll jump on this one. So, basically, certainly we have competition to increase bargaining power playing out in the Canadian context. I think part of what they did in the book is a bit of a historical overview of the growth of the U.S. system, and certainly in Canada, if a little bit of the history is helpful to understand some of the dynamics of the current bargaining that goes on. We have legislation and systems and resourcing, and in terms of resourcing, it's the human resources, the financial resources, and the infrastructure of our healthcare systems that were very much shaped by how medicine was practiced at the birth of Medicare in the mid-20th century. And so, namely at that time, hospitals were a place that you went for, acute care, for surgery, some drugs that were largely delivered in hospitals, and certainly drugs were not as an important factor in care delivery at that time, and physicians were the primary practitioners of care. With that legacy and with how we've sort of built our health systems, it's also led the general public to still understand the health system largely through the context of hospitals and physicians. And so their hearts and minds are still attached to these, and that makes political change difficult in the context of all of this competitive bargaining. So because of that history, it's now a challenge for our health systems to cover the gaps. So the treatments outside of hospitals, community-based mental health outside of hospitals, addictions services outside of hospitals, home care, primary health care teams, so not just doctors on their own, family physicians on their own, not just the rural country doctor that comes out to see you, but a team of interprofessional care providers working together, and the allied health professionals that are part of those teams, funding them as well, and the new diagnostics and the new technologies that are coming up. So all of these are challenged with the sort of historical legacy that we have built into our systems. And so, the bargaining that happens in Canada, there's an ongoing fight going on, and it relates to things like compensation levels, the overall allocation from the budget to different sectors, the scope of practice for different practitioners, the roles of different practitioners and healthcare providers within the health system. This happens, as it relates to providers and healthcare systems, so hospitals sort of vying against long-term care, against home care, against mental health, against abstinence-based addictions and harm reduction-based addictions, and primary care teams and solo practitioners and all that stuff. Professionals themselves are bargaining against each other in the sort of zero-sum fashion. And people are, and companies are trying to get different treatments covered, and generics versus brand name, and so all of the bargaining happening in that space as well. So these are some of the examples, again, that we could see in the Canadian context of this competition for bargaining power. And again, please jump in with any other examples you may have.
Well, one of the things that I find interesting, Louise, is that we pretend, I think, in Canada, that because we're sort of public, quote, a public system, although we're not very, really, but that we aren't, that there isn't competition, that we've tried to create a system that's really good for patients. And yet when you look at, but the truth is we do have lots of competition in the hospital sector. It strikes me that it's more what I would call institutional competition. It's like, you know, my hospital versus your hospital rather than, you know, my practice versus your practice, because they are paid generally by the hospital. People in there are paid by the hospital. So, but they want their hospital to do well. Otherwise, it won't keep going. So in the hospital sector, it seems to be more like hospital to hospital competition. And they have done some smart things in some areas, like deciding that one hospital will be the main cancer center and another will be a trauma center, and you know, that they'll kind of quote specialized quote, but I don't think they've done it anywhere near enough actually, in terms of what would really be effective and for patients. And when it comes to individual doctors, even though they also would have you believe they're not in competition, and in some ways they aren't, but in other ways they are. I mean, one of the things that I find annoying about my own doctor, and I don't know how many other people have this happen, but I mean, my doctor won't renew prescriptions unless you go in and get a new prescription. You know, which, I mean, I can understand that for some drug that you're being monitored for, you know, but for drugs that, like the ones I take, that I've been taking for the last 10 years, and probably will keep taking unless something happens, for me to go in and pay him just to sit down and have him write a prescription, I consider that to be a waste of healthcare dollars.
It really is. And how do we change that?
Yeah, and
so that's it. That's the thing. But if nobody's met, one of the ways to change it, I think, is to measure it. Like, I don't,
exactly.
You know, if, you know, until we start measuring that people are doing these things, and that don't go to Dr. X because he makes you go in, whereas Dr. Y will just fill your script over the phone unless there's a reason to bring you in. Yeah. And we don't measure that stuff very well.
Well, maybe we need to measure that. Yes, because, you know, when somebody goes into the doctor, do they have a code for renewing prescription? Does OHIP have
I'm sure they don't.
Yes or no?
They'll be billing for the visit. So
exactly.
And so so it's measuring. So it's, what are you measuring, and then how are you changing the different elements of the system to not incentivize the wrong thing. So we're actually going to get into the volumes thing in a second too, because right now the way so that's fee for service, that would be, you know, causing people to want to have you come in over and over and over again, because that's how they're getting paid, right?
Well,
so
and I mean, if you,
so it incentivizes the wrong thing. Yeah.
Well, and add to that, if I'm working full time, does this mean I have to take time off work to actually go down to that? Like, there's so many, you know, there's so many additional factors, not even just the fee to the doctor.
Exactly. So if you were measuring those larger outcomes, these different pieces within it would get highlighted as perversions in the system, and you'd be incentivized to tweak them. Just one last element, just to the point about the hospital versus hospital competition. From the experience I had in Ontario anyways, I would say definitely specialization has improved in urban areas where there's like larger academic hospitals and quite a few hospitals. There's been a lot of better specialization happening. The trend has happened within more rural and remote settings with hospitals is not it's actually a different dynamic in many cases of hospitals actually trying to take on the roles of community settings and take to become more generalist and to consolidate further and beyond their acute and sort of specialist care functions into, oh, well, we can handle the mental health and the primary health care and this and that, you know. So that's been the dynamic more in those settings, and it's actually been a bit of the strategy at the association level as well. Not a bit, it is the strategy at the association level too.
So are you saying, Leah, that what's happening in those rural settings is, rather than a sort of creative approach to serving those rural settings, it's all just kind of getting glommed into the existing system?
Yeah, Yes, exactly. Rather than figuring out how do we work together to better meet the needs of the population in our region, some of the dynamics that are happening out in some of these areas is it's the hospital saying, hey, all you other providers, let's consolidate under us, the hospital, so that we can do we can do everything for everybody. Right?
Which, of course, is the most expensive healthcare delivery in the world.
Yeah, and it goes against everything, as we're going to keep going through this when we talk about the different scoping the problems here, or not scoping the problems, so the root causes. You'll see that approach is the antithesis of how you want to go. Like, you want to be able to specialize better. You don't want broad service strategy. You want to be good for certain segments of the population or certain medical conditions. So by taking that, okay, we need to consolidate and we can do everything for everyone approach that hospitals are doing with the other settings, the home cares and the mental health people and the primary health care folks in these rural areas, they're basically going against what we're learning is an effective approach to move towards value-based healthcare. So I just, in the interest of time, so I want to keep us going, but just fundamentally, as Carol sort of noted, the cost shift, this whole focus on cost shifting, basically that struggle incentivizes system participants to amass more bargaining power, to capture more for themselves, rather than focusing on increasing the health outcomes, increasing efficiencies, increasing patient experience. There is this because there's a dynamic of cost shifting, who's going to pay, who's going to get the resources. There's a bargaining power dynamic that follows from that, right? Do you want me to throw it back over to you, or do you want me to do this slide to Carol?
Sure. Are we just saying, again, for like time, I think slides 5 we've kind of touched on.
Yeah.
And
so,
then
6 is all about, again, the fourth element of zero-sum competition that they mention is capture, the competition to capture more patients and to restrict their choices. And so some of the Canadian examples that we talked about, in Canada, there's been a focus when it comes to integration on consolidating providers. So in many parts of Canada, regional health authorities basically took over all the existing health providers and moved from being, sort of the bodies that did the funding and the accountability to being actual, managing healthcare and the frontline service delivery of healthcare. Not all, like Ontario hasn't really moved that deep down that approach. They did create local health integration networks, but they haven't actually made them healthcare providers. Other than recently, they made them healthcare providers for some home care with the CCACs. But there has been, for many LHINs, a focus on mergers and amalgamations and consolidation. The net effect is that this creates less choice for patients and more patients captured by each provider when you're taking that approach. By shifting physician remuneration to capitation, which requires patient rostering. This also incentivizes physicians that are paid in capitation for them to capture patients. And there's also sort of system, certainly in Ontario, there's system dynamics that incentivize family physicians to restrict patients from going to other providers, other practices. So I wanted to give one quick example of some models of primary care in Ontario, so you can get a sense of the capturing dynamic that goes on based on how they count. So to the whole data piece. So there's the family health teams and the community health centers. And family health teams, most of the doctors are paid with capitation, which means you're basically getting paid for how many people you have on a list of, who your roster. How many primary care patients do you have? So the bigger the number, the more you're going to get paid. So this incentivizes capturing patients, and the way they count how many patients they have, it can be, last I learned, this may be slightly outdated now, is they count anybody who's come into their practice in the last 7 years, even if they've never seen them for 7 years. So they're not giving them active primary care. If they've walked in the door once in the last 7 years, they're counted on the list for, and to get paid more. With community health centers, their physicians are salaried, and they're accountable to the executive director and ultimately to the local health integration networks, to the funder, for how many patients they're serving. And that number, called panel size, is further risk adjusted depending on the complexity of the people that they're seeing. So if they have medically or socially complex clients, then the number of people they're supposed to see gets adjusted mathematically to a slightly lower number so that they can spend the time that these types of clients require. And basically the way they count is anyone who has seen a family physician or a nurse practitioner in the last, I think it's 2 years, maybe 3 years, is counted as part of that, that number of primary care, that panel size number that they're accountable for. So they're really trying to make sure that these are actively cared for clients. And so it's just a difference in a particular model of care, with capitation really sort of incentivizing, get as many people on as you can, and it doesn't matter if you're actively seeing them or not. The more the merrier, the more you're going to get paid. Also in Ontario, there's choice restriction as it relates to who you see, basically because if you go see somebody else other than who you're signed up for, then that person gets penalized. So you don't really know it, but in Ontario, your primary care provider, your family doc, kind of owns you, quote unquote. And in fairness, I think what the government's trying to ensure is continuity of care, but also that they're only paying once. But it does ultimately result in choice restriction. It's certainly, people want to go see the nearest walk-in clinic, maybe not their far away family health team, but then they get their family health team doctor calling them and upset at them because they're having their payments deducted because you went to the walk-in clinic instead. So that happens in Ontario all the time. Over to you, Carol.
Okay. Slide 8. Why is competition at the wrong levels?
Excuse me.
So competition should take place for addressing medical conditions over the full cycle of care, including prevention, diagnosis, treatment, and the ongoing management of the condition. So right now, just a minute here, healthcare providers should compete to be the best at addressing a particular set of medical conditions or a particular segment of the patient population, or both. Patients and referring practitioners should be free to seek out the providers with the best track record over the full cycle of care. So I think that slightly touches upon what Leah was saying. Practitioners should be focusing on particular disease levels as opposed to broad disease levels, so that patients can get the best practice, get best care, and that we have choices. If one physician is not in that particular area, then we can go out and find another provider for whatever.
And they're informed choices, right? So these are the goals of value-based healthcare. So and this type of what do they call it? Win-win, not non-zero-sum competition, is what's going to help us, move in the right directions. But yeah, that specialization in either a particular set of medical conditions or a particular segment of the population, right? So is going to help get you there. And being responsible and measuring the full cycle of care, from prevention all the way to management and support, and that ability for practitioners, referring practitioners, and for people themselves to get online and see what are the track records over the full cycle of care, and so who do I want to be able to see and connect with, and that's basically should be the goal of the type of competition in the health system, and so we're working at the wrong levels to get there. And so the next part of the chapter is basically talking about what are those different wrong levels of what are the different assumptions that we're working from that are incorrect.
Can I just touch on that? So based on information, like as patients go out and they Google physicians to see, how are they rated? And what I found interesting, and I myself have done this, people often talk about the service that they received and not so much as, what was the value to them, like the outcome, like the health outcome. So, a doctor has a bad bedside manner. However, he or she, helped with my hip issue and so forth. So, and it's true, when I look over different reviews on physicians, quite often you get more of the personality of the physician and less about what was the health outcome with that.
Yeah. How long did they have to wait in the waiting room? What was their personality? Was it dirty?
Yeah. Okay. So now it's the still a competition of healthcare, commodity mindset. And as we all know, health is, should be considered a commodity. Like it's kind of a weird terminology for it. I never thought of using it in that way. So the commodity mindset drives the wrong objective for reducing short-term costs. Health is thought about as a thing that can be given from one to another, with individual components of the healthcare system priced out as a cog in a health machine. The system is structured as though healthcare were all one business, with all providers equivalent, all outcomes the same, and all patients sharing the same preference. So again, it's this needs to change, to not look at it as a thing that you can just buy. And then we go back to more of a value-based, like health outcomes. Anything to add, Leah?
No, keep going.
Okay.
Yeah, we're good.
So wrong objective over the wrong time horizon. So true cost and value are measured over the full cycle of care, from prevention to recovery and management of the condition. This is no longer time horizon. The focus can't be on short-term savings with long-term costs, but rather mid to long-term sustainability while achieving optimal results.
Yeah, I mean, fundamentally, it takes longer to assess outcomes over the full cycle of care. So you need a longer time horizon than currently. People are looking at quarters, annually. We're looking at very short time horizons, and we're looking intervention and provider by provider. So we're looking at the drug budget, we're looking at the hospital budget, we're looking at family physicians, we're looking at different types of specialists, et cetera. But and over that shorter time horizon, we're not looking at what's the full cycle of care, from prevention to management, to recovery or management. And by doing that, it forces you into more mid or long-term time horizons, and it also makes you think about the health budget as a whole, not just the individual costs for the individual widgets within the system.
Good. Any comments? No? Okay, so wrong geographic market. While most care is delivered locally, information, learning, standards, and competition should happen regionally, nationally, and even internationally.
Yeah, so this would require, obviously, there being metrics available across, to providers and to patients that would allow, care to be effectively delivered locally, but would allow people to assess how they're doing, within their jurisdiction, within their country, and even, looking at international potentially results, and who's doing what you're doing better, and how can you learn from them and get better too, right? So the linchpin to being able to do this are metrics that are available, measuring the right things and available to providers and the system, the system stewards, government, and as well as to people generally, the public.
Okay, wrong strategy. So the strategy should be to specialize based on patient populations or medical conditions or both, not to be everywhere, everything for everyone. So broad line strategies have little positive benefit for value. So again, this just touches on more of a specialty areas. There's like here in Ottawa, we have like the Heart Institute. So you wouldn't be sending somebody there for like a hip replacement. So it's better to be more focused than broad. The wrong structure of care delivery. Integrated, interprofessional, coordinated care across the spectrum of services should be the norm, not the exception.
Yeah. And so there are examples of where this is happening. Certainly I'm familiar with some in Ontario, and I know of some across the country too, but it's definitely not, I would say, I think it's being acknowledged in the literature, certainly as it relates to primary care, and I think probably more broadly, yeah, in terms of system-wide implementation of this, it's still, I think, exceptional.
The wrong industry structure. I think just looking at it, we kind of touched on.
So we chatted about this briefly when we talked about some of the hospital dynamics, certainly in rural and northern Ontario anyways, but in the book, they basically say that, they talk about the consolidation that's happened within the American system and the creation of sort of quasi-monopolies of health insurance providers there, and how that often leads to cost escalation, poorer quality, less innovation, less competition, and less specialization. And then in the Canadian context, again, this zero-sum competition has triggered consolidation of providers. It has played out as regionalization in many provinces and territories where all the providers have been consolidated under the regional health authorities. So again, moving from having responsibility for funding and accountability to actually providing all the service delivery. What I do know is that nationally there's been no research to demonstrate the effectiveness of regionalization. If you look at, and this has been a broader trend than just Canada, places like the UK, et cetera, have done similar approaches. And in many jurisdictions, there seem to be symptoms that it's not working beautifully, because you've seen the number of regional health authorities change a lot in different jurisdictions. And in some places like the UK and Alberta, they went from having, I don't know, however many, back to one regional health authority, as if it's the same as having one Ministry of Health. So they've contracted it back down to one after having sort of multiple, and there's a lot of change that's happened over the years. People have kind of played with these things, but there's been no rigorous research on effectiveness of this consolidated approach. But if when you read the book, they're basically saying, look, consolidation isn't where you should be putting your effort. It's the wrong industry structure. Specialization is a better way to go.
Mm-hmm. And I just want to add that it also, one thing that stood out to me in this area was it'll slow down innovation rather than speeding it up. Yeah. So we end up losing out on that. Are we good? The wrong patient attitudes and motivation. So informed patients are still the exception, not the norm in Canada. And it showed that patients who are informed, you don't want the most expensive medication. You don't want the latest, greatest testing. You're more informed. You just want to be, treated to the best and more value.
So really, what you're saying there is that patients should really know what the latest recommendations are. So, for instance, mammograms are no longer recommended as broadly as they used to be, and yet due to the conditioning that we've had over the last 30 years, most women feel like they are cheated if they
don't get a mammogram.
That's right. And so even though there's an education process underway, it's really difficult because even the doctors have difficulty with that new recommendation. So that's from the U.S. Preventive Task Force, who's recommending this based on all of the harms versus benefits over the last 30 years. So this is informed patients is an interesting interesting concept. However, we're not informed when we present to a physician with a problem and we discover we have something. We're not informed at that point in time. We just go along with whatever they say, right? So many patients just say, "Oh, my doctor knows best." So so there's the wrong patient attitudes and motivations, and there's also some physician education that is and prejudices or long-term beliefs that need to be addressed.
And what I found with this too is if you're lucky enough to have a physician that is going to work with you, because there's some physicians that they don't want to hear what your opinion is on your treatment plan.
That's right.
So I think that's important.
It really is. A dialogue between patient and physician is really important if the patient is willing to do it, because it takes mental power and it takes a desire to understand. And some people just don't want to do that, and maybe it's because they are sick. They just can't deal with it. So that's it is an unfortunate situation, but we can work to try and get people more informed generally, so that when a situation arises, they can start to explore the options and can start the dialogue with their doctor. So I'm really lucky because I have a doctor who's not in the family health care team, and he spends the time to discuss all the options and why this one, what's the result if you go this way, and what's the result if you go that way. So you're right. You need the doctor to play his or her role.
Okay, so we're on slide 17.
And just to add, probably just in the context of value-based healthcare, part of what would assist, I think, is having metrics that are showing what are the results for different types of patient populations and different health conditions, et cetera. It would help at least create some, it would help inform patients as well as providers. But yes, these larger. The larger, slower shifts of the dynamic between provider and patient and the trusting relationship and dialogue that needs to be developed is really paramount too. So how are people being trained? How are they being held accountable? And I think part of what they would say in this book is that this whole commodity mindset that people don't realize they've fallen into about health is part of what's driving this poor dynamic, because there's this kind of underlying assumption that you're going to get health from the provider, and you're there to receive it, right? So, and then there's the fear. Sometimes, if you go into a provider who is not giving you the signals that they're open to, that they're helping you with risk-benefit analysis, that they want to hear from you and your, what your thoughts and feelings and questions are. If they're giving you more the vibe of I know best and I'm giving you the information, and if you ask me questions, then I'm not going to be very happy about it, then that really can shut people down.
Well, and in addition, is all the social determinant stuff.
Absolutely, and with the social determinants, you may never make it there, right? You may not even make it. Maybe you'll make it into like the emergency department, right? So I mean, for some people, the social determinants are so bad that you're not even accessing healthcare whatsoever. And yes, certainly, if you are accessing it, you're not necessarily going to feel you're in a position to ask questions or
Exactly.
yeah, have any kind of power.
Yeah, interaction. Yeah. Exactly.
Yeah, yeah. So just wrapping up, we're almost there. Maybe I'll just zoom us through the end, Carol. What do you think?
Yeah, go for it.
Just because we have 7 minutes left. So the last piece is, as we said, we had a long chapter, and so they were going through all the different levels of what's happening that's wrong, or why aren't we sort of achieving the right level of competition. So they also talk about the wrong incentives for health plans, and so because we have this overall wrong objective of reducing costs in the short term, public and private health plans in Canada have the wrong incentives. If this is exacerbated by there being a 1-year budget cycle in government plans, and also a 1-year plan renewal cycle within health insurance. So that really is, forcing some very short-term thinking, and also forcing people it's not incentivizing any kind of savings across, that might be mid or long-term within the plan, and so it incentivizes further cost shifting, slowing down innovation, like it actually makes public and private health plans slow down innovations in order to slow down short-term costs. So no, we're not going to pay for that, new immunotherapy in the short term. And it also incentivizes them to complicate access and to complicate reimbursement, right? So how long does it take you to get on the public plan or on the private plan, and all the different hoops that they're going to put you through? The system is incentivizing this type of behavior currently. The wrong incentives for providers. So again, provider incentives are also misaligned. They're not, and instead what's being focused on is, as came up earlier, volumes, right? So fee-for-service, capitation, often this tends to incentivize volumes. Physicians will reduce times, it's not all of them, but many will reduce time spent with patients, will not pay as much attention to quality of care, and some dump patients that are more complex socially or medically in order to increase their volumes. Over-treating and under-treating, both, we talked about this already, both are being incentivized, and you actually get care patterns changing depending on changes to fee structures. So for example, in Ontario, when they reduced the fees for urine samples, all of a sudden all these methadone clinics started shutting down because the methadone physicians or methadone certified physicians were going to make less on the pee samples, so they just stopped doing the work and created a crisis in the province. It also, the misincentives for providers actually seek some providers end up exploiting the current rules, even though it probably leads to poorer health outcomes and certainly poorer patient experiences. So for example, in Ontario, primary care is often being delivered in rural hospital emergency rooms because there are incentives in the rural northern physician agreement that incentivize primary care providers to deliver hospital emergency room procedures, and hospitals want to have them there because if they don't have high volumes in their emergency rooms, they will lose their ability to have an emergency room. So these are just policy screw-ups that the providers exploit in order to make more money. And the system lacks incentives for improvement, though certainly in Ontario the concept of quality improvement is growing, but lacking incentives for improvement, innovation, system savings, integrated care, and results that matter to patients. And finally, they said, they feel that that employers are responding wrongly, that employers have exacerbated zero-sum competition by focusing on reducing short-term costs, not keeping employees well and productive, and they are cost shifting. And certainly this is happening in Canada by moving the costs more and more onto the employees, having them either pay higher premiums for less coverage or pay more and more for stuff out of pocket because they're not being covered, as well as to society by pushing people onto public plans for certain things, and taking it off of the private coverage. And that was our chapter.
So thank you very much. One thing that has nagged away at me about this book since I read it, and we aren't going to solve it today, but I'd like people to think about it and because it's really bothering me. And that's one of the premises in the book, is that it may be that people are going to have to travel farther to get care, that we may have to split things up in such ways that the expertise for particular diseases may not be as close to home as we're used to getting care. And I understand what they're saying, but it really is a bit counterintuitive in terms of patients and what patients are capable of doing when they're not well. And of course, in a country our size, our geography, how's that all going to work? And I'm not saying that this is an unworkable thing, but to me, it's one of the things that I think, from a patient side, forget about all the vested interests of doctors and hospitals that aren't going to like this. How do we make this work for patients? That was the biggest sort of barrier that I saw from a patient perspective that we might face.
Yeah, it's a really good point, especially when you look in the context, for example, in Ontario, where you have huge swaths of the province that really have next to no healthcare coverage because of geography, and so to make it even more centralized would make their access even more challenged if there aren't very thoughtful investments made in things, at least like telemedicine and way more transportation and all that sort of thing. So I think it's a good thing to flag for everyone as we read and this comes up, and what are our thoughts about that specific recommendation that they're making in the book.
It's Carol here. Based on what you said, Louise, isn't there, I don't know if it's in Ontario, but paramedics, haven't they started like a program where they're going out to elderly's homes to help with,
Yeah,
so,
there is Ontario. There are some examples of paramedics being used as health providers, basically with mobile outreach.
Right. And then the seniors only have to go in, to see their doctor or the hospital if the paramedic's assessment recommends it. So
yeah, definitely. Yeah. I think that's one sort of approach we could think about. Like, I think that's a really good one. And I think the more we can think up, ways that the system could deal with the issue of sort of remoteness. I mean, telehealth is one. What you're suggesting is another. There are ways. At the end of the day, though, it does suggest that for some people, for serious illnesses, they really are not going to be able to be treated to get good outcomes close to home. And so I agree with you. We should try to fill in as many gaps as we can close to home in different creative ways. And then maybe we just have to recognize and articulate to people, educate people as to why, as much as there's downsides to you having to go from home to get this, the upside is bigger than the downside.
Yeah.
I wonder, I'm looking forward to reading more and kind of chewing on this question, because I don't know if that assumption or recommendation they're making is accurate. I mean, I can think, if we're thinking about, if we're measuring the right health outcomes across the whole spectrum, and we're allowing innovation to flourish in that context and a variety of different scenarios to play out, and people are encouraged to specialize and et cetera, and partner across the whole system, so that you're making sure, from prevention through to sort of support, recovery, management, et cetera, that the costs are as affordable as possible and the outcomes are as best as possible, then I think you could end up with all sorts of delivery examples that may challenge this assumption or this recommendation. And I can think of some already that are happening, including for more problems like congestive heart failure, where outpatient services are being created in rural areas, but being linked to the regional hospital for more specialist, tertiary care. So there are examples, I think, already, though, that start to challenge this assumption. So I think it's really good that you're flagging it as a question.
Yeah, I think
Yeah.
some of it might be challengeable, and some of it I think just might be a reality.
Yeah,
you
and you
know?
just need to get better at telemedicine and better at transportation and better at outreach to be able to deal with it. Yeah.
Yeah, at least let's try to focus it where we really, really need to do it, and find other creative ways, as Martina mentioned, you know, to deal with the ones where we're doing it, but just because that's what we've always done, rather than thinking of something smarter to do.
Yeah.
A question of clarification: Where does that come up in the book? It didn't come up in
oh gosh, don't ask me to remember exactly.
We'll find it when we get there, Barry. I haven't come across it yet either, but I'm only on
yeah, no, it's
3 or
definitely,
4.
they definitely do talk about specialization across hospitals and stuff. It's going to require some people to have to travel. I can't remember exactly where. We'll find it. It's there. I was really acutely aware of it. No pun intended, but I was very aware of it at the time, and I thought, oh, I don't know, this is hard, you know, this is a hard one. So anyways, I'm sure, we'll find it.
It'll come up. So just because we're a little bit over, I want to thank everybody, and I just want to encourage, if you haven't signed up to help cover a chapter, please do. So far, we still need people for Chapter 3, Chapter 5, the conclusion, and the appendices. We have one person on Chapter 3 and 2 people on Chapter 4 for our next call. But if there's one more person who wants to join on Chapter 3, that would be great. So just contact me if you're interested in signing up and you haven't already. And our next meeting is July 30th at noon Eastern for an hour and a half again. Does 90 minutes seem to be long enough for folks?
Oh, I think so.
Okay.
Yeah.
And there's some chatting back and forth here, so please encourage you to read it before you hang up. I will copy out the pieces that are questions for Rose. Some people are thinking about some indicators that might be helpful, so I'll copy paste that and share that with you, Antonella, so that if any of it seems appropriate for Rose, you can share that with her. And thanks in advance to Martina for sharing the STAR article when you're able to find it. You may have already done it. And that's it. Was there anything else that people wanted to say and just didn't have a chance to? Sorry that we went a bit over.
No, it was a good conversation. It was a good conversation.
Great, thank you. Sorry, Gilbert, were you trying to say something there?
No, I was just packing up a very good conversation. I'll sign up for a chapter. I'll send you an email.
Thank you.
Very soon. It's just that I'm a bit busy with exams, so.
Totally understood. So the dates are there too. Feel free to sign up for something that's after your exams and gives you time to read and reflect and stuff. So.
Perfect.
Thank you so much, everybody. Have a fantastic.
Thank you.
Thank you.
Bye.
Bye, everyone.